morning, good afternoon, and good evening to our speakers, chairs, and audiences of ACNS webinars in different parts of the world. We are back again with another session of ACNS webinars with two wonderful speakers and chairs. The first speaker of today is our honored guest from the USA, Professor Walter Jean. Professor Jean is the Chief of Neurosurgery at the Lehigh Valley Health Network, Pennsylvania, USA. He is the professor at the Department of Neurosurgery and Brain Repair at the Morsani College of Medicine, University of South Florida. He is also the clinical professor at the Department of Neurosurgery at the George Washington University School of Medicine and Health Sciences. Professor Jean is the recipient of several awards and grants for his outstanding contribution to neurosurgery. His academic excellence is evident with the scores of publications that he has published over the years in various peer-reviewed journals. Professor Jean has kept his commitment to teaching to the young neurosurgeons globally with his online monthly lectures that he has named the Surgeon's Log. He is also the founder and chief executive officer of the Global Brain Surgery Initiative, which is a global neurosurgery educational organization. We are extremely honored to have him today as a speaker for our webinars, and today he'll be talking about the middle fossa approach. The speaker for the second session of today is our honored guest from Japan, Professor Yuichi Morofuji. Dr. Yuichi Morofuji is the chief neurosurgeon, Department of Neurosurgery at the National Nagasaki Medical Center, Nagasaki, Japan. He was a previous senior fellow at the University of Washington, USA. Dr. Morofuji specializes in the microsurgical and endovascular treatment of aneurysms, AVM, dural AVF, stroke, carotid artery stenosis, and brain tumors. He is passionate about basic translational research, focusing on blood-brain barrier as well. He has been principal investigator on several basic international research projects. We are extremely honored to have him today as a speaker for our webinars, and today he'll be talking about mechanical thrombectomy in acute ischemic stroke. The chair for the first session of today's webinar is our distinguished senior faculty from Japan, Professor Michihiro Kono. Professor Kono is the chairman at the Department of Neurosurgery, Tokyo Medical University, Tokyo, Japan. Professor Kono reserves his specialty in skull base and CP angle tumors and holds the record for the highest number of operated cases for vestibular schwannoma. He is an integral part of the Japanese Neurosurgical Society and has been academically active in various online educational programs. We are extremely thankful to Professor Kono for accepting our invitation to chair the first lecture of today's webinar. The chair for the second session of today's webinar is another distinguished senior faculty from Japan, Professor Shigeru Miyachi. Professor Miyachi is the professor and director of the Department of Neurosurgery, Neuroendovascular Therapy Center, Aichi Medical University, Aichi, Japan. He is the president of the Asian Australasian Federation of Intervention Therapeutic Neuroradiology. He was the past president of the AFITIN Congress in 2012 and vice president in 2014-15. He is a noted author with several publications in various peer-reviewed journals. He has received several awards, including the Best Doctor of Japan in the past. We are extremely thankful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the distinguished audiences to this online platform of ACNS webinars. Dr. Liu Boon Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to Professor Michihiro Kono.
Hi, everyone. I'm Professor Kono from Tokyo, Japan. The Olympic Games going to start here in Tokyo in the pandemic situation. Anyway, so it's my honor to chair Professor Jean, who is a very famous and hyperactive neurosurgeon. And middle fossa approach is very useful in trigeminal schwannoma surgery and meningioma surgery when we want to treat Meckel's cave, cavernous sinus, or prepontine lesions. So I'm looking forward to hearing his lecture. Could you start, please, Walter?
Okay, great. Thank you very much for that introduction, Michihiro. I am the Chief of Neurological Surgery at Lehigh Valley Health Network, and it's a true honor to be with you today, in particular because I am Asian, and you know, even though I live in the United States, so I feel very much part of the Asian community of neurosurgeons, and I am from Hong Kong, and I'm part of the Hong Kong Neurosurgical Society as well. So it's a great honor for me to be here speaking to you today in this very esteemed webinar setting. This is a very interesting topic that I was given, and I'm happy to talk about it. I'm very excited about this opportunity because it's not a topic that I talk about every day. And there are very interesting nuances about the middle fossa approach that makes it a very, very interesting topic. First of all, it's more than just one topic, really. Now, Dr. Kono just said that the middle fossa approach is very good for trigeminal schwannomas and meningiomas. I'm calling that the extended middle fossa approach that Professor Kawase is so integral part of. And I'm going to talk about that last and talk about that mainly as a contrasting idea to the middle, what I call the middle fossa approach, which is what Bill House invented for vestibular schwannomas that are intracanalicular. I'm going to spend most of my time in that direction because I think it's rarely talked about and rarely discussed at great lengths. So we're going to get to both subjects in a little bit. So the middle fossa approach that I think of as the middle fossa approach was invented by Dr. Bill House in 1961 at his clinic, House Clinic, right? And it really is designed specifically for vestibular schwannomas that are small, that are lateral in the canal, intracanalicular tumors, and with lateral extensions that are too far to do for a retrosigmoid approach, and in whom patients have intact hearing or usable hearing that they want to preserve. So that's the main topic, and it's a very unique topic for many reasons. Now that's a typical tumor that you would go after with the so-called middle fossa approach. If you know anything about me, you might know that I am very much into thinking about strategies and paradigms and schemes to follow to design operations specifically for skull-based surgery. And the first chapter of my book is all dedicated to thinking about how to approach skull-based surgery as a discipline and how to break it down so that we can design approaches in a more sensible way. And a lot of that first chapter is really based on Songzi's Art of War. Again, me being ethnic Chinese, I'm very interested in ancient Chinese wisdom, and the Art of War serves as a very good platform to think about modern skull-based surgery. So all these things that you see on the slide right now, far lateral approach, translabyrinthine, petrosectomy, whatnot, and you do see a middle fossa here in the middle here. I think of all these terms, all these elements as elements. These are elements of skull-based surgery. These are elements of the approaches. And as elements, they can be combined and exchanged and added on to each other to design the operation for skull-based tumors. But as elements, they serve one purpose, and that is the goal. The goal of the operation has to come first, most of the time, and then you pick the elements to then serve that particular goal. Example of a goal would be total resection. Example of another goal would be partial resection, et cetera, et cetera. So if an example of goal, brainstem decompression, if that is our primary goal, you have all these approach elements like the corridor and the craniotomies and clinoidectomy, whatever, these the elements that you can pick and choose to then make up the approach of choice. Another example would be something like that. These are the element of a corridor, the element of the craniotomy, and the element of something added, bony removal, so that you add all these things just like building blocks or alphabets into making, designing an operation. So the extended middle fossa approach is a common case of an element. What do you mean by that? It's an element that can be used to reach the petroclival region, specifically zone 1 of the clivus. And it's a common element because it can be chosen to serve any goal that requires that sort of reach. So if the goal is to say you need to get to the zone 1 of the clivus, you can use this as part of the operation to serve that goal. And it can be combined with other elements. You can open the bone differently. For example, an OZ can be added or part of the middle fossa, extended middle fossa approach, or the drilling the Kawase, the extended middle fossa approach can be part of the posterior petrosectomy to make a combined petrosectomy. So the extended middle fossa approach is an element that can be combined and chosen to serve a particular goal. And then so it's very similar to any other elements on that list. Now, the middle fossa approach, as designed by Dr. Bill House, is a very unique element. it actually I can only think of it as a standalone kind of case. It's entirely unique because it only serves one unique and specific set of goals. It does not serve most goals that we think of, decompression of brainstem, partial resection, total resection. It only serves one unique set of goals, and I'll talk about that in a second. And it does not usually combine with any other elements. It's very standalone, very put-offish, on an island sort of a thing. Now, what do I mean by all that? The unique set of goals for the middle fossa approach, for the house middle fossa approach, is simply total vestibular schwannoma removal. That is the only goal that that element serves. For any other goal, it wouldn't work. It doesn't really quite work. And the other goal that it serves is hearing preservation. Hearing preservation must be part of the goal of the operation for the middle fossa approach to be useful. And if you put those two goals together, you're really talking about cure. Okay, so again, the goal of the operation is cure of this very intracanalicular lateral extended vestibular schwannoma. I will then choose the middle fossa approach to serve that particular goal. And then so far, compared to all the other elements of approaches, is very unique. Okay, so let's talk about the middle fossa approach and its indications. When do you actually choose this element to serve those particular goals? It comes down to treat or not to treat. We either use that approach, do that operation to cure the schwannoma and preserve the hearing, or we don't do anything, or we stand back and we just simply watch and observe this very small intracanalicular tumor. So to first answer that question, to treat or not to treat, if you operate and if you choose to do the middle fossa approach on a patient, you must be confident, very confident, that you're going to do better for the patient than observation, because it's a small benign tumor, tiny little small tumor. That operation must have better results than observation. So when you talk about this topic with a patient, whether we should do the middle fossa approach or nothing, so first question is observation. Will the tumor actually grow in the patient's lifetime? And will this patient likely require surgery or require treatment in the lifetime? Now, obviously that has to do with the patient's age and health. If you have a 75-year-old with coronary artery disease and you're thinking about using the middle fossa approach, that's probably not a very good idea, because the tumor that you're treating is a tiny little tumor in a 75-year-old with coronary artery disease. Why are you doing this? The surgery may not be any better than observation in that particular patient. So that's why this operation is mostly used for very young patients who are healthy patients, because you have to say, oh, okay, in this patient's lifetime, this tumor will probably need treatment. It is already growing a little bit. It's a tiny little bit bigger in the canal. It will probably need treatment in the patient's lifetime, and therefore it is a good idea to think about the middle fossa approach. Otherwise, not. Good data now shows that the decline of the hearing correlates with the rate of tumor growth. So if the tumor is growing a little bit, then that's information that you can use about preservation of hearing. So preservation of hearing is also part of the consideration for observation. Sometimes we do the middle fossa approach to halt the progression of hearing loss, right? So think about this. The middle fossa approach, if successful, can preserve the patient's hearing at the status, preoperative status, and you remove not only the tumor, but the threat of progressive hearing loss in that patient's lifetime. So again, you have to be very, very confident about hearing preservation, but we'll get there in a second. So again, if you say to treat or not to treat, you're going to go treat with the middle fossa approach, you need to be thinking about the potential of halting the progression of hearing loss in the patient who's losing hearing because the tumor is growing very slowly. The other part of to treat or not to treat is that the middle fossa approach, if you're going to use it, you must be very confident that you're going to be better than radiosurgery. So obviously for small tumors, even if it's growing a little bit in the canal, one alternative is SRS, stereotactic radiosurgery. If you choose to operate with the middle fossa approach rather than radiate this patient, you better be confident that you're going to do better than radiosurgery. So hearing preservation is a topic, obviously very big for both. And it turns out that the rates are very similar, at least for the short term. Facial nerve preservation rates are better with SRS. So again, if you do this operation, you need to be very confident that you can preserve the facial nerve. Now, when it comes to facial numbness, that's when SRS is a little bit worse than the middle fossa approach, and that might be tipping you towards operating. So what do the short-term data say about the two things? So this is the middle fossa approach on the first column and radiosurgery. And this is all short-term data. Tumor control is very similar, right, in the short term. But hearing, preservation-wise, it's slightly better with radiosurgery. So again, it factors into your judgment and your skills and when you choose to use the middle fossa approach. And you have to know that the facial nerve injury rate is slightly higher with surgery. So can you do better? Can you do better than this 1% and whatnot? Now, if you look at longer term data, then that makes more sense to use the middle fossa approach, because after all, radiosurgery does not cure the tumor. And recall, part of the goal of using the house middle fossa approach is that you're curing the tumor. And by the way, if you cure the tumor, you also hopefully preserve the hearing at the preoperative status. Now, long-term hearing preservation for radiosurgery, as demonstrated by this paper by my friend Michael Link at the Mayo Clinic, actually tips us towards surgery. Even with low doses, the long-term hearing preservation for vestibular schwannoma for radiosurgery is less than a quarter at 10 years. So in that regard, only if you use that data to think about it, then it makes sense to, okay, if I preserve this patient's hearing with the middle fossa approach, it in fact is better than doing radiosurgery, because long-term radiosurgery hearing preservation is not that great, not as good as the short-term data. So again, back to the question of to treat or not to treat. Okay, we're going to go treat. We're going to use the middle fossa approach. You must be very confident that you can preserve the hearing. If you're not confident, you shouldn't use this approach. So what's our friend and what's our foe? Our foe, our enemy here, would be a T2 flare brightness in the cochlea. If you see this pre-operatively, you better think twice about using the middle fossa approach, because the hearing, the cochlea is already irritated. It is going to take a little bit of a miracle for hearing to be preserved in a preoperative state if there is very bright flare in the cochlea. The friend for us is the fundal cap. And by the way, a lot of this information is taken from my own webinar where Dr. Friedman was a guest and talking extensively about this topic. The fundal cap seems to be our friend when it comes to hearing preservation. And so if you see a fundal cap versus a T2 flare in the cochlea, you might say, okay, my confidence in preserving hearing for this particular patient is higher than the average. And here's the example of fundal cap. It simply makes it easy to dissect the tumor off of the basal turn of cochlea and whatnot. So fundal cap is a friend for hearing preservation, makes you more likely to use the middle fossa approach. The T2 brightness in the cochlea, you may want to think twice before choosing that approach. At the end of the day, and this is a very wise saying from Rick Freeman again, this is a very, very important concept for young trainees when you think about this approach. The middle fossa approach is the best way to preserve the hearing long term. Because think about it, as the tumor progresses, the hearing is going to go down. As radiosurgery long-term is not good for the hearing. Middle fossa approach, if successful to serve the goals of tumor resection, cure, and hearing preservation, is the best way to preserve the hearing long-term. But it also, for the patient, is the quickest way to losing it. Because on the day of surgery, the patient can lose it, boom, and then that's done as well. So patients can sometimes, very sophisticated, they look at all the information and say, I want my hearing to be preserved. I want the middle fossa approach. I want you to do it. You have to tell them, hey, for sure, it is most predictable way for long-term hearing preservation if successful. But if not successful, for example, if there's T2 flare in the cochlea, it might be the quickest way that you lose the hearing. That day of surgery, you're done, the hearing is gone. So are we willing to take that particular risk? So the modern indications for using this house middle fossa approach is to tumor less than 2 centimeters, intracanalicular. patient has to have usable hearing, otherwise this approach makes very little sense. And the patient's age less than 65. Less than 65, not because they can tolerate surgery better, but less than 65 in that they may have a long time to live for this tumor to grow, for them to require treatment eventually, for their hearing to be gone eventually. So that 65 number is right there. Now, that's, of course, a very soft number. You can have 75-year-old patients who are going to live a long time and very healthy that you might want to consider this. And of course, people who are older than 65 may actually come to you and say, I want this operation because I know what I'm getting myself into. I choose this operation because of all the information I have, and that's reasonable there too. So the fundal cap, again, is a friend that would tip you towards, and then no T2 flare would be something that would give you more confidence of using this approach correctly. So the technique. Using the lumbar drain is a 50-50 thing. Half the surgeons do, half the surgeons don't. It's really dealer's choice or user preference. The pro of using lumbar drain is it relaxes the temporolobal course because you have to go very, very medial to get to that Peters ridge. The con is that some people think that draining away the CSF actually removes a cushion for the temporal lobe and actually removes the protective effect of CSF. So no one's right, no one's wrong. Everybody has their own particular way. The patient is usually put supine, the head is turned all the way to the contralateral shoulder and dropped. The vertex has to be towards the floor because that assists in immobilization of the temporal lobe. And you can see that the incision is a curve or a straight line, doesn't matter, over the temporal squamosa, and then centered on the line of the medial plane. The craniotomy is flush with the base of the middle fossa, straddling the medial plane again, and then you have to take off that lip that blocks you from the floor of the middle fossa. And then finally, durotomy, you can open it any which way you want. It doesn't really matter that much. And you do need retractors because you have to go all the way to the edge of the Peters ridge to start the drilling. The first step intracranially is the identification of GSPN. You use a probe for this, an electric monitor, and we always try to dissect the GSPN from posterior to anterior so that you don't actually avulse the nerve as you move forward. The GSPN is a very important landmark and easy to find because you can use electrophysiology to find it. And it's a very important landmark so you can find the meatal plane. After all, finding the IAC is then the next big task in the operation, and the GSPN helps you. So originally described by House, how do we find the IAC? You follow GSPN back to the genicular ganglion. You actually expose the bone over the genicular ganglion very, very carefully. And then you find the first genuine facial nerve and you follow it from lateral to medial to find the IAC. I think very few people do this now because it's very easy to hurt the facial nerve this way. Hugo Fisch has his way, finding the superior semicircular canal, which is on the surface of the middle fossa. It's the arcuate eminence, and then you try to find a 60-degree angle from the arcuate eminence. Now, mind you, the arcuate eminence is often very difficult to confirm if you just look at the middle fossa floor, and that 60-degree angle, I for one don't have protractors in my eyeballs, so I don't know how to measure 60 degrees per se. So there are better ways of doing that nowadays. Again, I think this is the way that most people do it, which is first find the GSPN, then find the arcuate eminence, and then simply bisecting that angle to find the IAC, the meatal plane, that way. And this was a contribution by Garcia Ibanez. My friend Ravi Sami at Cincinnati talks about doing this, which is blue lining, drilling the bone very, very carefully over the arcuate eminence, actually finding the superior semicircular canal, and then opening all the bone that is in front of that. So all the bone in front of that is going to be safe. All the bone in front of that, and tracing that facial nerve, opening that meatus halfway down the facial nerve in the labyrinthine segment. So make yourself a lot more room so that when you dissect the tumor, you don't put traction on that facial nerve and hurt it when you're resecting the tumor. Now, there are problems with that technique that we will talk about in a very short while. All right, so, and I'll tell you how I find the IAC in a little bit. Once you've done all this, you find the facial nerve distally, then you open the tumor capsule, you debulk some of that tumor, and then you finally dissect the tumor from medial to laterally, and then gradually take it off of the facial nerve, and then resect it in total. And again, total resection has to, so here's the operative video that I will show you most of. Let's hope that we play is okay. Now here again, same diagram about the opening and the craniotomy. I'm showing you the craniotomy in virtual reality here. I use two burr holes, one in the base and one in higher up superiorly, and then it's a square shape craniotomy with the center of the craniotomy at the meatal plane or the eye or the external canal. Here you see that I can actually make the bone translucent and see the tumor in virtual reality. And that way, there's absolutely no question as to where the tumor is. And, you know, you don't have to bisect any angles. You're just drilling right over the tumor and making enough room to dissect the tumor safely off of the facial nerve. And you're leaving everything else alone. All right, so here's in real life. So you dissect from lateral to medial, the dura off of the floor of the middle fossa. You find the GSPN, again, from posterior to anteriorly. You find the nerve finally with the probe, which here's right there. There's the dehiscence of that canal. You're using the probe and very low voltage to confirm that that is a GSPN. And then this is my otology friend, Dr. Jeffrey Kim, a long-term partner doing the drilling here. He's identified the arcuate eminence, which is very clear in this particular regard. And he basically takes all the bone that's anterior to it and find the IAC deep. And as you near the IAC, you can use that electrophysiological probe again to find the facial nerve so that you know that you're right there. There it is. You find that at the IAC, and then you finally open it much wider. Make sure you don't put traction on the facial nerve as you dissect the tumor. Laterally, you have to be very careful that you don't drill into the cochlea now. So now that's enough opening. You're going to open the dura over the superior aspects of the tumor. That is the brainstem. You don't want to go there. The tumor is a little bit more anterior than that. Okay, here it is. There is the last piece of the dura that's open over the tumor. That's all dura that's just blocking you. There's a tumor. Now, then the next task is finding that facial nerve in front of it. Since these are fascicular schwannomas, the facial nerve is going to be anterior to you and superior. You debulk a little bit of the CP angle component of the tumor. And then you really need to look now for the facial nerve. If not laterally, then at least the brainstem, and there it is. So it's caked with a little bit of blood. The probe says, okay, there's your 7. And now once you've found 7 in the brainstem, then the rest becomes a little bit simpler because you're not working blinded. The best way to saving the facial nerve is actually seeing it so that you can protect it. At the beginning, there seems to be very little plane between the tumor and the 7th nerve. You have to be very, very, very patient, and this takes however long time it needs to develop that plane between the facial nerve and the tumor. And then finally, it is developing. This is a very sharp Rosen pick. Now the round knife. And just to save some time, we ultimately were able to find a plane, and then it goes from the dissection of the tumor goes from medial to lateral. Here's finally the plane between the tumor and the facial nerve. There it is. And then you can mobilize the tumor posteriorly, and out it comes. And then again, debulking it. And then finally, the lateral component, you may need an endoscope. You may need a angle endoscope. You may be very careful about leaving tumor laterally. And then you will obviously want to preserve because hearing preservation, it has to be a goal of your surgery. So you have to uncover the cochlear nerve finally, laterally. And then you wax in. And at the end, after you take out the tumor, you put some wax in there, make sure it doesn't leak, and you close up shop. That is, in a nutshell, the middle fossa approach. Potential complications. Well, you have to serve the goal. If the goal is not met, then you have not completed your goal. So hearing loss and incomplete resection are potential complications. What is autophony? Autophony can happen if you blue line that superior semicircular canal a little bit too much, so you can hear yourself talk. That is a possible complication if you use that technique about blue lining the SSC. CSF leak, obviously, for obvious reasons. But this temporal lobe thing, in my opinion, has not been talked about enough. Because of the retraction and mobilization of the temporal lobe to get so medial, you can affect the temporal lobe. And I'm not talking about hematoma or anything disastrous like that, but there's a good study from way back when that showed that up to 86% of these patients post-op have EEG changes. Not frank seizures, perhaps, but EEG changes. So you got to think about this very carefully when you're lifting that temporal lobe up so high to do this operation. So this is my way of now finding the canal. We've already talked about, it's not simply using navigation anymore. Navigation requires a monitor and you have to turn your head. I can use this augmented reality to look straight at the floor of the middle fossa and see X-ray vision where the cochlea is and where the tumor is, so that I can stay away from the danger areas and operate only in the relevant areas. And here's a demonstration of this. You can see that the anatomy is projected through a microscope in augmented reality onto this is a printed skull, by the way, for demonstration. All the anatomy is well aligned. Things are where they're supposed to be in both augmented reality and real life. And so in this case, you simply drill from medial to lateral again, right at the tumor. The green thing is where the target is. All the yellow things are lateral to it, and you want to stay away from those things because that's the labyrinth and your cochlea. And then using this technology, of course, the microscope is integrated with navigation, so it knows where to go. With this, there is really no doubt as to where the drilling needs to be, or where the IAC is, or where the meatal plane is, because there it is, there's a tumor, and you will eventually get to it. Again, I'm not going to belabor the point given the time that we have. All right, so let's stop this and move on. Let's see. Okay. All right, so just a brief word about the extended middle fossa approach, which is a much more common approach element, can be combined with all kinds of corridors and as well as all kinds of craniotomy openings. This is a beautiful tool to reach the petroclival region, particularly in the top zone of the clivus. And it can be combined with, it can be used for many goals that, as long as it needs to be there, get to that area, and it can be combined with. Now, of course, this is a picture of Dr. Kawase, without whom there is no such thing as an extended middle fossa approach, and this was taken in Beijing last year. This is his area. I wish I had my own area in the skull, but not yet, at least. This is Kawase's quadrilateral, and by the way, for the young trainees in the audience, it's really not a triangle. People call it a triangle. It's really not it's a I call it quadrilateral. The boundaries are the fifth nerve, the third division of the fifth nerve, the GSPN laterally, medially, it's the Petrus ridge, and in this case, you see the superior petrosal sinus, and the posterior border really is the meatal plane, and you can go as deep as the IAC. On that meatal plane. And that area, if you drill it out, gives you a huge amount of freedom to get to that zone 1 of the petroclival region. And again, meningioma, trigeminal schwannoma, whatever you're trying to remove in whatever fashion, that is to say partial resection, complete resection, brainstem decompression, you can use this as part of your approach. Now, this is a graph from a paper that's coming out in August. We used, again, virtual reality models to look at the amount of freedom, surgical freedom you have with the anterior putrescectomy or Kawase's approach. And this is the proximal clival fissure, petroclival fissure in the ipsilateral side, the midline clivus, and then finally the basilar artery pushed by this petroclival meningioma all the way to the other side. You can see that the anterior putrescectomy gives you a huge amount of freedom at the ipsilateral petroclival fissure, and not bad at the basilar artery. It's a little bit limited at the midline clivus in zone 1. The anterior putrescectomy is the champion approach to the zone 1 of the petroclival region. It's better than retrosig, it's better than translab, better than retrolab to get to this top zone, which is dorsum cellular to the IAC of the petroclival region. And please read this paper when it does come out in August. I think you'll be interested in the findings. I don't know that we have time for this, but we'll show how to do this very, very briefly. This is the kind of tumor in zone 1 of the petroclival region that you want to take out. And this is the perfect approach to use for something like this because it eliminates, again, all the bone that's in your way. So again, it's very similar to that first video. You dissect the Petrus ridge. You find the GSPN and anteriorly, you find the posterior border of V3, and then you start drilling. And you go deeper and deeper and deeper. And the goal here is to expose enough of the posterior fossa, lateral posterior fossa dura, so that you can open that. So that's enough. Okay, so the first cut of the dura is subtemporal, right underneath the temporal lobe. The next cut is perpendicular to that in the posterior fossa dura, deep to the plane of the surgery. And then finally you cut along the tentorium to open that whole area up. And then there's the root of the trigeminal nerve, and then you finish opening up the tentorium without hurting the trochlear nerve. In this case, the trochlear nerve is pushed medially by the tumor. And then you debulk, and you find all the other neurovascular structures that are medial to you that are important. I believe that's the SCA. No, that's actually the fourth nerve. Oh no, that's SCA. So again, basilar artery and so on. I'm not going to have time to show you this entire video because I do want to talk about one nuance. The critical thing about this approach for young trainees, this is the hardest thing to understand. It's how those dural cuts actually intersect. So again, after you drill out that area, that Kawase quadrilateral, again, boundary is, GSPN is here and the V3 is here. Your dural cuts are really perpendicular to each other. The first cut is at the base of the temporal lobe. That's easy to understand. What's not so easy to understand is this cut that's down here. This orange cut is the lateral aspect of the posterior fossa dura that is perpendicular to your first cut. And then in between that is the superior protrusal sinus that you have to ligate. And then once again, you have to cut basically along the same cut to cut the tent without hurting the fourth nerve to complete this opening so that you can take the tumor within this area. Again, augmented reality, very useful. You can see all these structures in augmented reality in your microscope. So again, you don't hurt those areas. You can't hurt the cochlea and the labyrinth that way. And here's drilling the Kawase region. All right, so this is my final word here. A lot of the information I gave out today, especially about the Bill House middle fossa approach, was taken from this webinar that we made about a year ago. If anyone is interested in all the details, please go to this on YouTube, on our channel, Surgeon's Log channel, YouTube, and look for Blue Jean Baby LA Lady, the tiny dancer, right? This intracanalicular vestibular schwannoma. Everything that I said really was taken from this. Robbie Sami, Norberto Andaluz, and Rick Friedman really gave out a huge seminar on this. Lots of diamonds that were dropped wisdom wise, and you can learn from them much better than you can learn from me today. So I will stop there and stop sharing. I think I'm right on time, and take questions. If I went over something way too quickly and there are questions about it, we can revisit that a little bit. But that's a lot of information to digest in half an hour.
Thank you. Thank you, Professor Jean. So I enjoyed your educational lecture. About the small vestibular schwannoma, so I can't realize the merit of using the middle fossa approach because the middle fossa approach is very difficult, I think. Much bleeding, temporal lobe trouble or something, and disorientation. Why don't you use the retrosigmoid approach for small vestibular schwannoma?
Well, because in my hands, for very tiny, for tumors that are completely in the canal, with just the smallest component in the CPA angle, it's in my hands very difficult to get to that lateral component from the posterior fossa retrosigmoid approach. The other problem is that if you drill out the canal from the retrosigmoid approach posteriorly, so right, obviously the middle fossa approach, you're opening the canal, the roof, opening the top of the canal. Whereas if you have to go all the way laterally for the intracanalicular tumors from the backside, which is the retrosigmoid side, you have to drill very laterally from the backside, and there's potentially of hurting the endolymphatic system, hurting the cochlea and other structures. That very lateral bit of that bone drilling becomes very scary. Now, I know you're very good with using the angle endoscope, and you can always look around the corner with the angle endoscope that way. But at least in my hands, if you have a very purely intracanalicular, very laterally extending tumor, opening the roof of the canal really is a very elegant way of dissecting the tumor off of the facial nerve and whatnot. Point well taken about the temporal lobe. The temporal, you have to be very, very careful about protecting the temporal lobe. In my personal operations, I do like using the lumbar drain. I think that makes it easier, and I had to tug less to get to that medial ridge. So I'm a fan of the lumbar drain. I don't know. I have never actually tried, to be honest with you, a purely intracanalicular tumor taking out retrosig. But I can tell you that my experience with the middle fossa approach, fortunately to this day, is very good. So.
Okay. And so you do so lumbar drainage for anterior transpetrosal approach or middle fossa approach, and so what do you do? Do you use the pedicle subgarrial flap or something to prevent CSF leak, other than lumbar drainage?
Yeah. I have so far not used any sort of pedicle flap. That I've learned from actually all the Japanese speakers seem to use this very, very widely. I forgot what I was talking about last week. I think I was with one of your trainees, Ken Matsushima,
Matsushima,
and he was talking about using that pedicle flap in there.
Yes,
I have not used that. I wax the air cells very, very carefully intracranially, and then I do have that lumbar drain to help me at least first couple of days post-op. So very fortunately, I have not had a leak from the anterior petrosal approach or the middle fossa approach. But I'm beginning to learn from you all how to turn that pedicle flap in there, and that seems to be a very easy and elegant way of stopping, having an add barrier in there. Good point.
Professor Nair, please.
Yeah. Walter, it was an excellent lecture, educative lecture, and I also agree with Professor Kono that retrosigmoid approach can take these tumors with much ease. And let me ask you 4 queries. And first query is, so what is the durability of hearing? You talked about Link's publication that only 25% of the patients with gamma knife have hearing preserved after, good hearing preserved after 10 years. And that is my question number 1. Second question is, say, do you do any investigation to find in middle fossa approach from which nerve vestibular, whether the tumor is arising from superior or inferior vestibular nerve by doing electronystagmography? That is my second question. Third question is, you told very correctly about bisecting the angle between the 60-degree angle between greater superficial petrosal nerve and over the arcuate eminence. But that applies only for true lateral position. When you combine it with anterior procedure, the angle between GSP and IAC reduces, as opposed to when you come posteriorly through a petrosal approach, angle between arcuate eminence line and IAC again reduces. So that applies only for true lateral. And my last question to you is, as Professor Kono correctly told, say venous bleeding can be dangerous. Do you always do DSA to see whether there is any variability, whether there is a sphenopetrosal vein or there is a sphenobasal vein? If that is there, it can be treacherous to do a middle fossa approach. So all the 4 queries, Professor Walter, please.
Wow. Okay, let's go by one here. Okay, first hearing.
Hearing, durability of...
Yeah, so the beautiful thing about using this approach is that if the hearing is preserved after surgery, that's what they get. That they're not going to be threatened by surgical debris or post-operative recovery or the tumor anymore. The tumor is gone, and the longevity of the hearing preservation is usually permanent.
Is it correct? Because there have been publications from group from Los Angeles also, say any approach, durability of hearing, because there can be fibrosis, scarring all inside. it can definitely affect hearing in the long term. So if you have attacked gamma knife, hearing status is not preserved, same thing will apply for surgery also, any surgery. And so my view is that. Okay, my second question to you is, what say you told about the angle between IAC and blue line, the 60-degree bisect between GSP, and that applies only for true lateral. Suppose you move the head, you approach from anteriorly, or approach, do middle fossa to as a part of posterior petrosectomy, that angle varies. So that is also, it's also difficult to find IAC in such circumstances. And
okay, so difficult, no doubt. There's nothing easy about this approach, which is why you have to be very, very confident about your experience and your skill to do this. There's nothing easy about finding the IAC. There's nothing easy about finding that, bisecting that angle. That angle obviously applies to morphometric studies where you're looking at the floor of the middle fossa right straight on, right? And your point is well taken. If you turn the head differently, you're looking at the floor in a different way, it doesn't appear to be bisecting anymore. But that bisecting is purely talking about morphometric anatomical studies where you're looking at those angles and you say bisecting.
okay,
As I said, most people don't actually do that because most people don't have protractors in the operating rooms, right? The experienced otologists, the experienced people doing this approach would look at the arcuate eminence, maybe blue line the superior semicircular knot, and understand that anything that's anterior to that but posterior to the trigeminal nerve is safe to take. So they drill out all that area to make room for themselves for the tumor dissection. So, that again, I don't particularly use that anymore because I got navigation and more sophisticated.
You told that. Point taken.
But
anatomy. What about venous anatomy? Do you study venous?
That's a very good point. I get CTAs and CTVs on everybody pre-op. I have not had an occasion where I say, oh, there's venous anomaly here, I better not do it. Remember, everybody's very, of course, careful about Labbe, and that is very important when you're doing an anterior petrosectomy because, after all, this is an intradural operation when you open the dura and you have to work around those veins. For the Bill House middle fossa approach, there's nothing intradural there. The only intradural component of the House middle fossa approach is in the canal, and the canal and a tiny little bit of the CP angle. So the veins really don't play a big role in the middle fossa approach for the vestibular schwannoma operation that we're talking about.
But especially if they have a sphenopetrosal vein or spheno-basal vein, there can be treacherous bleeding. And last question, say if you know beforehand if the tumor is arising from inferior vestibular nerve, you know you are going to cook up the hearing. So do you do electronystagmography? I will just tell, if electronystagmogram is normal, you pursue that the tumor is arising from inferior vestibular nerve, with the pathways through the superior vestibular nerve. If it is,
I absolutely agree. I agree. Whatever tool you can to make sure that the tumor is coming from the superior nerve should be used. I'm not sure how reliable it is. You may still run into situations where you find that it's from the inferior nerve, but very fortunately, vast majority of these tumors are from the superior nerve, and preserving that cochlear nerve, which is anterior to you, should be easier. Again, for the audience listening to this, this is not an approach that you do once in a blue moon. There are centers that do this, and it really, you need to be confident that you're going to meet those goals, which are very high goals, right? They are very, very high goals: cure and hearing preservation. If you're not confident in that, this is not an approach that you want to just kind of dabble in, if you will. I don't have enough experience to talk about the intracannular tumor coming from retrosig. And I would love to see Professor Kono's videos on this particular topic, because I bet you it's going to be spectacular with endoscopes and all that. So I would love to learn about that.
Thank you, Walter. Thank you for the great lecture.
Thank you very much, Professor Walter Jim. That was a wonderful lecture. As you said, this is not an approach that anybody can do. It takes some level of experience and practice before anybody can attempt on these very difficult tumors. I think it is time we can go back to our chair for his concluding remarks before we go on to Professor Morofuji, because most of the things have already been discussed by Professor Suresh Nair and Professor Walter Jean. Yes, Professor Kono.
So there are very so many problems about the middle fossa approach. So it's very so difficult approach, I think. So simple is best. Please please do a retrosigmoid approach for the small vestibular schwannoma. And this is my conclusion. Thank you.
Right. Thank you very much. Before we go on to the next session, I would like to inquire if Professor Walter Jean would be staying back to hear the second lecture.
I unfortunately I have an aneurysm case that's going, so I would have to bid you farewell. Thank you for the invitation. It's been a true honor, and it's great that we disagree, because that's how debate happens and everybody learns. So
thank you very much, Professor Walter Jean. I would like to inform our viewers that there are around 800 people watching us live on different channels, YouTube, WeChat, and Zoom. So it has been a very fruitful discussion for everybody. I would like to hand over this session to the second chair, Professor Shigeru Miyachi Sensei, to say the introduction part of the second lecture.
Okay, so yeah, after such a photo discussion, the next topic is neuroendovascular therapy. But that is in our field. This is so very hot topics for the acute stroke, as well as this coiling for the acute ruptured aneurysms. And so now all over the world, this thrombectomy treatment option is so highly so generalized. And also in Japan, is the several seminars for the training of this neuroendovascular new technique. And so many neurosurgeons, many neurologists and strokologists want to learn this technique. And now, as so very large number of the small society of this local society to organize this treatment option to generalize in the local area. I think Professor Morofuji is one of the experts of this techniques, and he's the specialist of neuroendovascular. I think are you now in the National Hospital in Nagasaki? No.
Yes, National Medical Center. Yes.
Medical Center. Yeah, and before you were so working in with Professor Horie.
Yes.
So I think this is one of the very aggressive institute of such a neuroendovascular therapy. So Professor Morofuji, please start your lecture of this acute stroke within the neuroendovascular thrombectomy. Please.
Thank you very much for your kind introduction, Professor Miyachi. Hi, everyone. Good night from Japan. It's 10 p.m. here. I'm Dr. Yoichi Morofuji from Nagasaki, Japan. And it's a great honor to me to be able to speak to you at ACNS webinar today. First of all, I would like to thank Professor Yoko Kato and all the staff of this webinar. I made my presentation with a pre-recorded style, so today I'll be talking about mechanical thrombectomy for acute ischemic stroke. I have no financial disclosure or a conflict of interest with this presentation. I'm Dr. Yoichi Morofuji from the Department of Neurosurgery, National Nagasaki Medical Center, Nagasaki, Japan. Nagasaki is located on the western edge of Japan. As you can see, South Korea is much closer than Tokyo for us. So I graduated from Nagasaki University in 2001 and started my neurosurgical residency. And I got my PhD in 2010. My basic research topic was blood-brain barrier. I've also studied abroad as a senior fellow at the University of Washington from 2011 to
2015. My supervisor was William Lance. We are still collaborating each other with a couple of research projects of blood-brain barrier. I came back to Nagasaki University in 2013 and proved myself as a dual-trained neurosurgeon. And then last year, I moved to Columbia Institution, National Nagasaki Medical Center. My critical specialty is direct surgery and endovascular, especially for the cerebrovascular disease. I'm still working on a basic research project with some PhD students of the surgical department and collaborative institutions in the United States and the European countries. In this presentation, first I'm going to talk about general description of the thrombolysis and mechanical thrombectomy. After I chose the topic how mechanical thrombectomy for this seminar, I noticed that mechanical thrombectomy is performed in limited hospitals in India and some Asian countries, and usually performed by neurophysicians. So this part might be boring for endovascular surgeons. Please bear with me. Then I will show you our effort to get good clinical outcomes for patients with acute ischemic stroke. I want to focus on imaging and transportation system. After that, I will share with you about my basic research for acute ischemic stroke in reproduction. The basic strategy for acute ischemic stroke, especially for large vessel occlusion, is quite simple. The only thing we have to do is to recanalize the occluded vessel. Case of right ICA occlusion, if we could not recanalize the occluded ICA in this case, the patient will suffer from left hemiparesis for life or may die because of brain edema or the other complication like pneumonia. However, if we get recanalization of the right ICA, the patient will recover from left hemiparesis completely. As you can see, the ischemic area on diffusion image after lead perfusion is minimal. Then, how can we recanalize the occluded vessel? I will talk about historical aspects. Around the year 2000, when I was a med student or young resident, I watched our senior neurosurgeon tackle the recanalization of large vessel occlusion using the endovascular technique. The main method was intra-arterial infusion of bloodless and mechanical disruption of the clots using micro guide wire and micro catheter, which is called piercing technique. The micro catheter is passed through the clot and positioned on the distal side of the thrombus and then start intra-arterial infusion of bloodless. If the micro catheter cannot be passed through the clot, local infusion into the clot or proximal and 1 second. The randomized control trial Approac 2 demonstrated the potential benefit of intra-arterial thrombolysis within 6 hours, but FDA did not approve it as acute ischemic stroke treatment. Another trial, a Japan study, was terminated prematurely because the approval of intravenous TPA. We still sometimes use this method for distal embolization, but intra-arterial infusion of blockers have not widely spread for standard therapy for acute ischemic stroke. On the other hand, pharmacotherapy for acute ischemic stroke, intravenous TPA has emerged. In 1995, NIN's TPA study published in New England Journal of Medicine, it took 10 years to get approval of IV TPA therapy in Japan. In 2008, ICA-3 trial demonstrated that treatment of IV TPA between 3 and 4.5 hours on the onset from the onset of the ischemic stroke significantly improved clinical outcomes. 4 years later, in 2012, we can use IVTPA within 4.5 hours in Japan. For us, standard therapy to regionalize the occluded vessel was IVTPA for a long time. Since the publication of ISAT, endovascular coiling for intracranial aneurysm has been widely used as an alternative to surgical clipping for aneurysmal subarachnoid hemorrhage. However, the role of endovascular therapy for acute ischemic stroke was still limited. IVTPA was established as a standard therapy for acute ischemic stroke, and IVTPA is effective, especially for mild symptom of stroke. IVTPA has potential drawbacks. First, increasing the risk of intracranial hemorrhage and other bleeding complications. And then, the low rate of recanalization for large vessels. Recanalization rate of ICA is 5.9%. That of proximal MCA is 17%. As a result, possibility of returning to normal daily life is low. In case of large vessel occlusion, the percentage is below 10%. The number of indications for IVTPA was limited, and even IVTPA was performed. The effect of IVTPA, large vessel occlusion, was not satisfactory. Then, back to endovascular side, the male sewage liver system was first stroke thrombectomy device approved by FDA in 2004. The MELC device is a flexible corkscrew-shaped device made of nitrile wire to catch the thrombs. Another first-generation device, the penumbra system, was designed to remove the clot by aspiration and extraction. I have little experience with these devices because I was away from clinical work around this period. Liver stents emerged as new devices for acute ischemic stroke therapy. The stent was originally developed for adjunctive use in intracranial aneurysm treatment, but they were used off-label to recanalize the occluded vessel. Some case reports of this technique are published. Subsequent retrospective studies demonstrate a high success rate and fast times achieved for recanalization. This is a very initial case of mechanical thrombectomy with stentless liver, which has really surprised. The case was basilar artery occlusion. His Glasgow scale was 4, and he suffered from tuberculosis, and he was also intubated. Mechanical thrombectomy was performed without any difficulties. Immediately after clot removal, he recovered from his unconsciousness and presented no motor weakness. He was extubated his airway on angio suite table. As we have experienced a number of cases of mechanical thrombectomy with stentless livers, of course, it exists in many different areas, but the procedure itself is relatively easy, and the risk of complications seems to be low. Almost all the stroke surgeons, stroke physicians, and neuroradiologists believe that mechanical thrombectomy must be a game changer for acute ischemic stroke therapy. However, in 2013, 3 initial RCTs failed to demonstrate conclusive benefit for endovascular therapy. Some of the failure of these trials Honolulu shock because these results were presented at ISC in Honolulu, Hawaii. There are some weak points of these trials. CT angiography was not required, which allowed the inclusion of patients who did not have large vessel occlusion. First-generation devices were used, and recanalization rates were low, and initiation of treatment was delayed. After the 3 negative trials were published, the tide turned in 2015. 5 randomized controlled trials provided compelling evidence that mechanical thrombectomy improves outcomes for acute ischemic stroke. The results of these trials were presented at ISC Nashville, and all trials were published in New England Journal of Medicine. The AHA-ASA guideline was updated in 2015. Patients should receive endovascular surgery for anterior circulation with a stentless liver within 6 hours as class 1. In 2018, diffuse-3 and DAWN trials demonstrate that some patients may benefit from thrombectomy after 16 hours and 24 hours after symptom onset respectively. And again, guideline was updated. The next and the latest question is, do we need IBTPA prior to mechanical thrombectomy for large vessel occlusion? 2 studies came up this year concerning this question. We should wait the result of additional studies, but in my personal opinion, considering the risk of hemorrhagic complications and cost of IBTPA, we may be able to skip IBTPA in the near future. Stroke thrombectomy is one of the biggest game changers in medicine. The stroke treatment has completely changed in the last 5 years. We need to set up the new system to perform the mechanical thrombectomy appropriately. Next, I'm going to talk about our effort to get good clinical outcomes for patients with acute ischemic stroke. To get good clinical outcomes, first, we need to shorten the time until recanalization to save as much brain tissue as possible. Secondly, we need to increase the rate of recanalization. And then, we need to reduce the complication during the procedure and postoperative costs. To avoid the complications and the worst clinical outcomes, we should be careful to select the candidates for mechanical thrombectomy. During the IBTPA period, one of my colleagues, Dr. Tadeishi, he is a stroke physician, he implemented the stroke code and studied nurse-initiative IBTPA therapy. The project NGK48 was named after Japanese famous idol group AKB48. I think this is a good idea to apply a catchy name for the project, because stroke medical care needs a lot of staff, not only doctors and nurses, but radiological technicians, laboratory technicians, clerks, and so on. The catchy name was useful to spread the project for all the staffs in our hospital. As a result, door-to-needle time was significantly reduced. Next, we changed our therapeutic protocol for patients with stroke to reduce door-to-puncture time in 2014. It was before the publication of famous 5 randomized controlled trials. The major changes were early contact to endovascular surgeon before MRI acquisition, and early decision-making for IBTPA and mechanical thrombectomy during MRI. In this study period, door-to-puncture time was reduced by 30 minutes. CD is the most widely used for acute ischemic stroke patients. However, we have used MRI for stroke patients since IBTPA therapy period. MRI has some advantages over CT. Diffusion-weighted image can provide the reference for ischemic core, which is crucial in selecting patients for mechanical thrombectomy, especially in the later time window. Our target time for door-to-puncture time is within 60 minutes. Our stroke MRI protocol takes 20 minutes. Our unique point of stroke MRI is to apply arterial spin labeling ASL. I will talk about ASL later. This is a representative case in our department. To minimize the delay for thrombolysis or endovascular therapy, patients usually stay in an emergency room within 10 minutes and are transferred directly to MRI unit right after checking the NIH stroke scale. We take stroke MRI sequences in this order: diffusion, MRA, SWI, ASL, and FLAIR. Then we make a decision for IVTPA and endovascular therapy by ML angiography. Door to puncture time was just 1 hour in this case. This is a result of our preliminary study. Our new workflow system reduced in a 30 minutes reduction in median door to puncture time. For every 5 minutes today in endovascular perfusion, 100 patients has the first disability outcome. It's clear the time between stroke onset and reperfusion is of great significance. In this study, we focused on door to puncture time to reduce in-hospital delay, but we should pay attention to our endovascular technique and enlightenment for staffs, general physicians, and also community. The next is how to increase the rate of recanalization. First, I will show you the data from Nagasaki University between 2013 and 2017. This table shows the comparison of 5 famous randomized controlled trials in 2015. We included the endovascular therapy for posterior circulation as real-world experience. We used several kinds of stents and aspiration catheters. Mean age was higher than aspect score was lower than other 5 trials. Both good recanalization rate and the good functional outcomes at 90 days were almost the same as the other trials at that time. Several companies have provided a couple of new aspiration catheters and stent retrievers recently. A new generation of highly navigable large aspiration catheters and retriever devices for mechanical thrombectomy has markedly improved recanalization rate, time, and clinical outcome. New techniques based on combined aspiration catheter and stent retriever have published recently. I did not mention the technique one by one today. I think using the balloon guiding catheter and proper aspiration of the blood are important to get good clinical results. The good recanalization rate of reported studies were quite high. Now, we fixed the system for endovascular therapy for large vessel occlusion. For anterior circulation, we use balloon guiding catheter, aspiration catheter, and mitral catheter and wire like this. And we usually use combined technique. For posterior circulation, we do not use balloon catheter and aspiration catheter. We use stent retriever only. Proper guiding placement in a timely fashion is important. So we sometimes need to change the access route to reach the target vessel. One example is transbrachial approach. It's in about 5% of cases. A guiding catheter was difficult to advance into the target vessel because of tortuosity and elongated aorta or other factors. In this case, a guiding catheter could not advance into the right internal caudal artery due to severe femoral artery tortuosity and type 3 aortic arch. We successfully achieved recanalization in substantially reduced time via transbrachial approach and treble probe catheter through a full French catheter without a guiding catheter. In our institution, mechanical thrombectomy is mainly performed by two young residents. One is a neurosurgeon, the other is a stroke physician. The good recanalization rate is around 90%, and puncture to recanalization time was 45 minutes. Good functional outcome at molecular ranking scale between 0 to 2 at 90 days was 42%. This is a bit low, but I think it's mainly because of baseline characteristics. Next is how to reduce complications. To avoid the complication of mechanical thrombectomy, identification of the stroke subtype before the procedure is very important, including stroke associated with cardioembolism, atherosclerotic, severe stenosis, and chronic occlusion. We should be very careful. For atherosclerotic cases, it may exist chronic occlusion, which is not suitable for mechanical thrombectomy. The patient's history and laboratory data are also helpful to evaluate the etiology. BNP and HAP may serve as biomarkers for cardioembolism. Compared to CT, our MRI protocol is useful to distinguish atherosclerotic lesions from cardioembolism using combined with T2 still susceptibility sign, flare vessel signs, and unique ASL signals. This shows the case of 42-year-old woman with sudden onset of lobar aphasia. MRI showed left MCA occlusion. Mechanical thrombectomy with combined technique was performed, and we could get regionalization, but severe vasospasm remained at the site of stent deployment. Vasospasm usually occurs due to catheter and microguide wire manipulation. Some trials reported arterial vasospasm occurred in 3% to 20%. We reported this case because the patient suffered from symptomatic vasospasm. After thrombectomy, mechanical stimulation caused by stent retriever may cause vessel injury, and additional post-stroke inflammation might also induce many delayed vasospasm. I'm going to talk about how to select the candidate for mechanical thrombectomy and how to predict the outcome before the thrombectomy. Determining the occlusion site and collateral blood flow is important in acute ischemic stroke. Arterial spin labeling, ASL, is one of the most recent magnetic MRI sequences used to assess brain perfusion non-invasively. It can be used in the acute stage of ischemic stroke to identify ischemic penumbra. ASL has been incorporated as a stroke evaluation in our institution. We have frequently encountered imaging findings in ASL that are unique hyper-intense signals inside and around the affected regions. The purpose of our first study was to test whether ASL could be used to identify the occlusion site and collateral perfusion in patients with stroke using DSA as a gold standard. The data was collected from our ongoing stroke registry. 20 patients were retrospectively reviewed. 32 patients who met our inclusion criteria were analyzed in this study. All MRI studies were performed at 1.5 Tesla MR system with 8-channel head coil. Total acquisition time of our stroke MRI protocol is 20 minutes. ASL were performed using shoot continuous ASL pulse sequence. Labeling duration is 1.5 seconds, followed by 2.5 post-labeling delay. We named this unique hyper-intense signal of ASL intra-arterial sign, IAS. Proximal IAS was defined as enlarged circular or linear bright hyperintensity within occluded vessel, and distal IAS was defined as enlarged circular or linear bright hyperintensity within artery inside or surrounding the hyperfused area. In this study, we evaluate the presence or absence of both proximal and distal IAS. This table shows the patient's baseline characteristics. Median age is 78 and HLI IHSS was 15. The time between MRI and DSA was about 1 hour. Half of the patients received IPTA. I will show you some representative case of intraarterial signs. MRI revealed right M1 occlusion and ASL image showed a wide area of hypoperfusion in accordance with right MCA therapy. When we see ASL carefully, we found a small dot hyperintensity on ASL in occluded M1 and also detected a couple of linear hyperintensities inside the hypoperfused area. We call this hyperintense signal on ASL proximal IAS. DSA confirms occlusion of M1, right M1. This IAS inside the hypoperfused area on ASL would indicate left meningeal collateral from ACA territory. The clear depiction of proximal and distal IAS on ASL demonstrated stagnant flow in front of occlusion site and delayed collateral flow on DSA respectively. This slide shows 3 cases of left ICA occlusion. MRA of all cases could not visualize left ICA flow. The upper case, no proximal IAS was observed on ASL. DSA revealed absence of intracranial flow. In the middle case, proximal IAS was observed in petrous portion of ICA and stagnant flow was detected in petrous portion on DSA. The lower case, proximal IAS was observed in C2 portion of ICA. DSA revealed severe ICA stenosis and saw stagnant flow in C2 portion lasting till the late venous phase. In this case, MRA shows no flow signal by lateral vertebral arteries and vagal artery. However, ASL could detect proximal IAS, which means stagnant flow signal of vertebral artery. Distal IAS, in accordance with left PCA, was also shown. The occlusion of the left vertebral artery and left meningeal collateral from the arterial circulation to the left PCA was confirmed by DSA. As I showed representative cases, proximal IAS on ASL means stagnant flow in front of occlusion site, and distal IAS means delayed collateral flow on DSA. They show diagnostic value, sensitivity, and specificity for identifying occlusion site with ASL were high. Those for identifying collateral flow with ASL were also high. Interlateral agreement was good for both proximal and distal IAS detection. The hyperintense vessel sign on flare in a useful imaging marker of acute ischemic stroke, although process mechanisms have not been elucidated. It is likely to involve the arterial occlusion, collateral flow, and the static blood flow. We confirm our distal IAS could indicate left meningeal collateral flow using DSA. The susceptibility vessel sign on T2 star is also a well-known marker of arterial occlusion, but sensitivity was reported only between 27 to 50%. In contrast, proximal IAS, that means stagnant flow just proximal to occlusion site, was more consistently observed in our study. In conclusion, the proximal IAS and distal IAS on ASL imaging can provide important diagnostic clues for the detection of arterial occlusion sites and collateral perfusion in patients with acute ischemic stroke. We reported that ASL could be used to identify the collateral perfusion in patients with acute ischemic stroke. Our next question was, can distal IAS on ASL, which indicates collateral flow, predict functional outcome of endovascular recanalization. We included the patient with successful reperfusion and 53 patients included in this study. In this study, we evaluated the presence or absence of distal IAS. You can see the dot-like hyperintense signal inside the hypoperfused area on ASL, distal IAS. Distal IAS means left meningeal collateral flow. This is a representative case of successful reperfusion with poor collateral status. Diffusion weighted image showed small hyperintense signal in the right insula cortex and MRA revealed light ICA occlusion. ASL could not detect any distal IAS in hypoperfused area, which means poor collateral status. Despite successful recanalization in only 3 hours from onset, the patient suffered from the infarction of basal ganglia and hemorrhagic transformation. This is another representative case of successful reperfusion with good collateral status. Diffusion weighted image on admission showed small hyperintense signal in the right basal ganglia, and MRA revealed light ICA occlusion. ASL showed a couple of linear distal IAS in hypoperfused area. Successful reperfusion was achieved over 12 hours after onset. The patient recovered from his left hematolysis and postoperative MRI showed no additional infarct. This table shows the summary of our results. Time from onset to reperfusion was around 4 hours in both groups. Good functional outcome at 90 days was 80% in the distal IAS positive group as compared with 17% in the negative group. There is a huge significant difference. The major finding of our study is that the rate of good functional outcome at 90 days in the distal IAS positive group is much higher than that in the negative. All 11 patients without distal IAS in the arterial circulation resulted in modified Longitudinal scale between 3 and 6. Negative distal IAS might be predictive indicator for poor outcome, but this result is not applied to posterior circulation, probably due to unique collateral system or physiologically longer time tolerance in the posterior circulation. Of course, time is important. On the other hand, in this paper, authors found degree of collaterals and not time is a determining factor of core infarct volume within 6 hours of stroke onset. This is one of the papers which supports our results. In conclusion, we provided preliminary evidence that good clinical outcome following successful reperfusion is collateral dependent as well as time dependent. Our MRI imaging-based workflow with arteriospin labeling is effective to identify the patient who may benefit from endovascular treatment. We need to establish an effective system to increase the number of thrombectomy eligible patients, hospital by hospital, region by region. Let's get back to my hospital. Nagasaki Prefecture has 51 inhabited islands, the largest number in Japan. About 120,000 people are living in these islands. However, there is no stroke physician in the islands. National Medical Center is the hub center for all these islands hospitals. For the management of patients with the AIS on these islands, we have established the helicopter transportation and teleradiology system that operates 24/7. It's very exceptional, but we can use maritime self-defense force helicopter during the night time. Of course, onset to puncture time in island group was longer than mainland group. However, the good functional outcome has almost similar to mainland group. From last year, we started to direct angio suite system for patients from other hospitals to avoid any hospital delay. The number of patients with drip-sip and leaf is dramatically increasing lately. I will move to the final topic, future perspective for treatment for acute ischemic stroke in this reperfusion era. Central nervous system disease represents one of the most challenging therapeutic areas for successful drug treatment. Neuroprotective drugs for stroke have all failed in pivotal phase 3 efficacy trial, mainly because the drug cannot cross the blood-brain barrier. How can we develop CNS targeted drug like stroke? Almost all large molecules and water-soluble molecules cannot enter the brain. There are a lot of target diseases affecting the BBB, even for the neurosurgeons. To study these diseases, we have developed in vitro triple culture BBB model with primary culture of brain endothelial cells, pelycytes, astrocytes, and microglia. In this model, we can easily evaluate the barrier function, permeability, cytokine dynamics, and also create disease model. To strengthen the blood-brain barrier integrity has an important role in protection against the development of neurological disorder like including stroke. We have been exploring BBB protective drugs using our in vitro model. Our main goal is to protect brain from ischemic insult. We have reported that statin and ALB seems to have BBB protective effect in both ischemic and hyperglycemic condition. Ischemic stroke therapy has now entered the era of highly effective reperfusion. Combining neuroprotection with intravenous or intra-arterial reperfusion therapy is now an important next step in the development of acute stroke therapies. However, even in the era of rapid and effective recanalization, using endovascular approaches, the percentage of patients with good functional outcomes varies between 33% and 71%. It is important to close the gap between high recanalization rates and worse clinical outcomes. Low kinase was recently described as a novel molecular target for neurodegeneration. The low kinase inhibitor Fossa as a promising drug candidate influencing several mechanisms with relevance to neurodegeneration. Our recent data here indicates low kinase inhibitor Fossa strengthens the barrier integrity against ischemic condition. We use contrast media, of course, in mechanical thrombectomy. Therefore, we investigate the effect of contrast media on BBB. Contrast media, as well as ischemic insult, cause transient and reversible BBB opening. Taken together, intra-arterial passage administration immediately after thrombectomy may be feasible and have BBB protective and neuroprotective effect in ischemia. Fossa are routinely employed intravenously and selectively intra-arterially for vasospasm after subarachnoid hemorrhage in Japan. Considering this fact, intra-arterial passage administration may be also safe for the patient with acute ischemic stroke. Intra-arterial passage administration immediately following thrombectomy is safe and may become a useful pharmacotherapeutic option for acute ischemic stroke. Hence, mechanical thrombectomy is now the gold standard for acute ischemic stroke treatment. neuroprotective strategy via the intra-arterial route are highly anticipated. Mechanical thrombectomy is now the gold standard for acute ischemic stroke treatment. Reducing treatment delays by improving workflow can improve the efficacy of acute reperfusion. Our MRI-first strategy, including ASL, may work to detect the eligible patients for thrombectomy, especially in daytime window. Neuroprotective strategy with intra-arterial routes are highly anticipated for acute ischemic stroke treatment. Thank you for your kind attention.
Okay. Thank you, Dr. Mofuji. That was a very excellent lecture. And so he talked so about the very wide topics and including so the history of the mechanical thrombectomy and the indication of this option. And so finally, you mentioned about the neuroprotective, that's the pharmacological approaches. This is a very new topics. So I have several questions, but so in the audience, are there any questions or comments for him?
You may start with your questions and then we will ask the audience, Professor.
Okay. So I have two or three questions about the indication of this mechanical thrombectomy. You talked so very clear, so eligible patients selection using so rapid or such ASL or other many MRI images. Do you limit some so criteria for the absolutely the extra indication patients? Do you have some protocol?
Yeah, I think it's a good question. Actually, so I showed our results using the ASL, especially ASL MRI system. If when I judged this patient has low collateral flow, in that case, so even in that case we can do the thrombectomy, and then in that case, so we need to hurry, I think. And then if the collateral flow is enough using my ASL system, so I think we still in a hurry, but we still have a little bit afford time to do the surgery. So actually, so kind of like, you know, we are kind of like aggressive to do this therapy because the number needed treatment is 2.8. It's a very effective treatment for the patient.
Yes, I agree. We tend to be aggressive because of some social situations, for example, in hospital patients, and that is so if the already the ischemic area is shown in the MRI, we must do it. Yeah. So, but I think a very important point is as you say that the collateral and the time. So I think this is a balance, and maybe we always consider the ischemic core and the penumbra area. I think that is maybe the clinically the mismatch, the symptom and the MRI image. That is maybe the most fastest way to select the patient, and so we expect the patient's outcome. Yeah. And as a question is so your final topics in the pharmacological, particularly in the phosgene chloride.
Yes.
That is very interesting, and that is the agents for the vasospasm.
Yes.
Yeah, we know because the phosgene is so developed.
Yeah, so in Nagoya, so yeah, so Nagoya University.
Yes, this is a calcium antagonist, but that is, yeah, we know that is to open the blood-brain barrier, but I cannot understand where. So that is the function to blood-brain barrier to protect the infiltration of the, so for example, so edema or some ischemic necrosis, but that is maybe this infusion of the fascia should be before the ischemic attack. After the ischemic attack, it's okay. This is too late, or how does
I think it's still okay.
Okay,
Because,
okay.
yeah. So another point is we also check the effect of the contrast media on the blood-brain barrier. So you may know. So I think even in the United States, they use a mannitol therapy before drug delivery to the brain. I think using the contrast media is kind of like the same system to use the mannitol before the treatment.
Yeah, that is used in the arterial infusion of the anti-cancer drug for the brain.
And I think the same thing happened using the contrast media, and firstly also the beneficial effect on blood-brain barrier. So I think it's a good idea in near future.
Okay, yeah, it's very interesting, and so it's a very bright future. Yeah, and also the final question is, yeah, I know that Nagasaki Prefecture has a lot of islands, and we know that you are so big trouble, big you are facing the big problem to transportation.
Yes.
Yeah. How do you manage such a transportation? That is some good system with an emergency system, or the ambulance or
So in the case of the island, in the case of island, so we have the teleradiology system. We can check the MRI in a hospital. So we can use the teleradiology system. So before the transportation, we can check the MRI, the diffusion MRAs. So and then recently, so just transport to our hospital, and we don't take any laboratory check, because we already have the data from the previous hospital. So we transfer the patient from door to directly to the angio suite to reduce the time.
Yeah. Now the two ways, the drip and sip and the drive and retrieve. Yeah. Do you, how do you think? Yeah, it is difficult, but
yes, right.
Some cases, Dr. Harry cannot fly in the night time. So at that time, that you go to the jet boat or by plane is to go to the island with an escape patients.
In the nighttime, so we still use a helicopter because kind of like it's not a Navy, but the self-defense forces helicopter. It's I think it's exceptional, but yeah, we can use. Even in the nighttime. Yeah.
Okay.
It's a little bit take time, but still okay in the kind of midnight. We can transport the patient from the island in the midnight.
Yeah. Okay. Good system for the cooperation.
Yeah.
So other questions? Okay.
We can ask my co-host, Dr. Liu Bun Singh. Any comments from your side?
Yeah, thanks, Rajat. Thanks, Professor Morofuji, for a very extensive discussion on thrombectomy. I have 3 questions for you, Professor. Firstly, in cases that fail thrombectomy, do you have option for bypass? If you have, which patient will be benefited from bypass, and what are the blood parameters that you're looking at, or do you have any specific regime of transfusion to correct, especially after RTPA? My second question, Professor, in which cases that you use barbiturate coma, diuretic, and also hypothermia? Is that part of the treatment modality that you use, especially those delay cases with very bad edema or you suspect raised intracranial pressure? My last question is it possible in the future we may be able to do away without MRI? We just relying on CTA and CT perfusion to decide whether those patients can be benefited from thrombectomy. Thank you, Professor.
Okay, the first question you're asking about bypass. So I think in the case of atherosclerotic case, so we have, if we get the reperfusion, but still the severe stenosis, we usually do not bypass in an acute stage, and we usually use the dual antiplatelet therapy for a couple of months, and then we apply the bypass, even in severe, even there remains a severe stenosis. Of course, we could check the brain perfusion and in a kind of like the chronic stage, and then we apply the bypass. And the second question is the hypothermia, right? About hypothermia.
Yeah. Hypothermia, barbiturate coma, and also diuretic. Mannitol, when you use all this routinely, hypothermia, barbiturate coma, and mannitol. Yes.
Or for acute ischemic stroke.
Yes, true.
I have a couple of experience the hypothermia for the traumatic patient, but I don't have any case for hypothermia for acute ischemic stroke patients. Is it okay for you?
Yes. And last question.
Last question is, so the possibility of the CTA, right?
Yes, and CT.
I think it's normal to use the CTA and the CT angiography. MRI is kind of like I think it's very low number of the institute to apply the MRI for acute ischemic stroke. The MRI takes time compared to CT. So I think it's okay, but the good point to apply the MRI is we can guess the composition of the thrombus, kind of like it seems like the cardioembolic or atherosclerotic or others. I think a little bit more information to use the MRI, I think.
Thank you, Professor.
Thank you very much. We can conclude this session. We can hear the concluding remarks by Professor Miyachi.
Yeah, it's a very nice lecture and a good discussion. And in the last question, that that is a very important point because in the Asian, in Japan, the MRI has all MRI is set in all the hospitals, all the general hospitals. So there's a lot of machines of MRI is generalized in Japan, but other countries are very poor situation. So in such a case, now the MRI skip or TPS skip, that is a big question, and it's a very hot topics in our field. So I think we must consider to such an very poor situation in the derivatives or the equipment. So we must consider the more simple method to achieve this option. If not, this is not generalized in the other Asian countries. So that is very good points.
So thank you very much. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to sincerely thank both the speakers of today, Professor Walter Jean and Professor Yoichi Morofuji, and the chairs, Professor Michiro Kono and Professor Shigeru Miyachi, for the time and support for the ACNS webinars. A very special thanks to my co-host, Dr. Liu Bun Seng, as well as Professor Shubin, who has mentored us since last 1 year. And he has arranged broadcast of WeChat of this webinar in China. And today we have around 835 participants who have joined us live. A special thanks to all the special audiences and guests, Professor Suresh Nar and all the distinguished people who have joined us. So until we all meet on 24th, it is bye-bye from all of us. Thank you very much for joining.